Gustafson. I am a nurse midwife in Boise. I am also a certified menopause practitioner. I decided after years of working in full scope midwifery that there was just not enough answers for women after childbearing was finished, or women who don't go through childbearing at all, and just get to their 30s, 40s, and 50s and start to feel really dismissed and like they're going crazy. And I just, when I learned about menopause as a practitioner and found that other doctors, nurses, midwives, nurse practitioners I was working with didn't have the answers that I needed, I thought that was really appalling. And it's a huge disservice. And also, I really love learning about menopause because it really brings together all of the wisdom and, you know, the life wisdom that we learn. Really, we have to dig so deep in this time in our lives, and get to use that. So it's really an awesome topic, and I'm so glad you guys are here. We are going to take questions at periodic points. Please let me know if there's any issues too, because with Zoom, if you can't hear me or something, somebody's got to let me know because I have no idea. So cool. So hopefully in this class, you'll come out with a better understanding of what is perimenopause and what is menopause. I love this quote from Oprah. I love that Oprah got involved in the menopause conversation in the past year. She really highlights that this is not an ending, although physically in our bodies, it can often feel like an ending. But it's actually a new start to reinvent yourself. And, you know, once you're free from the constraints of reproductive cycling, which we have been living under since puberty, you really have an opportunity to say, well, who am I? Not in relation to other people and not in relationship to the world, but who am I in myself, and how do I want to live this next half of my life, hopefully, if you're lucky enough to get to this stage. So I think that's a really empowering note, and I hope that we can kind of come back to that as we go through. This is very much focused on sort of it's not as much focused on the emotional and spiritual aspects of menopause, but this is a placeholder to say there is a huge growing support out there of women who are talking about the spiritual transformation of menopause. And this course, we're going to talk about the physical and psychological transformations, which are difficult. And we're going to talk about hormone replacement therapy. So we're going to kind of go in a different direction. But this is equally important. Okay. Okay. So let's start with some terms. So you have perimenopause and menopause. So perimenopause just means before menopause. Also, the term premenopause means before menopause, and so these terms can get very confusing. So perimenopause usually symptoms first start usually 7 to 10 years before your final menstrual period or final menstrual cycle. So you can be having symptoms. Usually women start experiencing symptoms or noticing something shift around age 40, but it can be earlier, and it certainly can be later. Perimenopause has a lot of symptoms because as our hormones are changing, there's a lot of things that lots of parts of our body start to notice that our hormones shift. And we're going to talk all about that today. It's also a critical window for health, as I'm sure everyone here is aware. A lot of your health things change. You know, maybe your lab markers change. Maybe all of a sudden your cholesterol has gone up out of nowhere. Maybe your fatigue levels have increased, like you're not able to exercise as much, or some things are really changing, or your sleep is deteriorating. And all of that can have a big effect, not just on our quality of life, but also our overall health. And it's puberty 2.0. We're going to talk more about that. Perimenopause is reverse puberty. So it is not just 1 year of your life. Puberty is, 10 to 12 years of your life. And it's the same with perimenopause. It's the reverse puberty. So fun. Okay. Now menopause is basically just means your menstrual periods have ended. Menstrual cycles have ended. So when you've gone 12 full months with no bleeding, no period, or no menstrual cycling, then you know that you've entered menopause. Women can live up to half their life in menopause if they're lucky. So this is very significant. And usually symptoms as they start in perimenopause and they continue once you reach menopause. It's not like, oh, that's the last day, it's over. You reach menopause and then symptoms you're in this menopause transition for a couple years and then they gradually improve. So, I didn't want to throw too many terms in here, but you see on the bottom, can you guys see if I move this around, this cursor? Okay. So perimenopause leads to the menopause transition, which now you're in menopause, and then you're in menopause forever after that. So I like to say you reach menopause, not that you went through menopause, because that doesn't make sense, because you're always, once you reached menopause, you're always in menopause now. One of the permanent changes that happens in menopause is there's urinary changes to the urinary tract, your urethra and your bladder, and changes to your vulva, your vagina, your clitoris, your labia. And we're going to talk about that too, that those are some permanent changes that happen in menopause. But a lot of the symptoms of perimenopause, a lot of them are temporary, although they do last a long time. Okay, so the average age to reach menopause in the US is 51. If you are having menstrual periods, then you'll know you've reached menopause once it's been 12 full months with no period. Then you can have a menopause party, you can blog about it, and you will probably end up feeling, a lot of women report feeling a sense of relief by that point. Like, okay, I'm really glad to be through it now. If you've had a hysterectomy or an endometrial ablation, and so you don't have bleeding anymore, or if you have a hormonal IUD and you don't have bleeding anymore, it does not mean that you won't go through menopause. I see this all the time. Women come in their mid-50s and they're like, well, I had a hysterectomy a long time ago. I kind of just thought I wasn't going to go through menopause. And that's really the disservice there is on the physicians who did the surgery. Why didn't they explain that? Okay, that really gets me kind of upset. But if you have ovaries, if you still have ovaries in your body, you will go through all the same hormonal changes like everyone else. The only thing is you won't have bleeding. So sometimes that can be an added layer of like a mystery. Where am I in this process? And in that case, when we don't have bleeding to kind of track, then, we go by symptoms and we go by some labs. But it's not it's not that mysterious, because if you reach this age and you're having all these symptoms, we can be pretty darn sure it's menopause. I put this in here just as a public service announcement. If you have vaginal bleeding after menopause, that's never normal. So you should always get that checked out. Any questions so far? Okay, well, since this is all about menstrual cycling. So again, if you're not having periods, you are still cycling. You're still having this rise in hormones that peaks, and then you would ovulate. You're still ovulating, and then you're not ovulating, and then you're having a period, whether or not you bleed or not. So I just wanted to review this because we're going to go through some terms, and a lot of times people need a little refresher on this. So this is just what happens in the female hormone cycle. Let's say its average is 28 days, which would be 4 weeks. Week 1, you're bleeding. So your hormones are low. All these 3 hormones here, estrogen, progesterone, testosterone, are all very low. Then estrogen gradually rises to a peak here, and testosterone also rises at ovulation. And then it falls. And then it rises again. And then it falls, and then you have a period. So you get 2 rises of estrogen, and you get 1 rise of progesterone, and then it falls, and then you have bleeding. And then a new cycle starts. This is kind of a wordy slide, but I really just want to give you a sense of the flow. Like, menopause is a time in our lives that we have reached, and that everyone will reach if they live that long. So there's these milestones. You're born with a certain amount of ovaries. Now, research is starting to challenge that. We don't know that that's actually true, but that is certainly what we've all been taught, that we're born with a finite number of eggs in our ovaries. When you're a girl, you don't have any estrogen and your ovaries aren't doing anything. So in girlhood, it's a mini menopause state. It's a hypoestrogenic state, meaning you don't have estrogen in your bodies. So your vulva, your vagina, your breasts, nothing's growing. Everything stays very closed in girlhood. Puberty, all of that starts to turn on, and you start cycling, and it's a full-on roller coaster for 8 to 10 years. It's not just an easy process. Then, you finally get through puberty, you get to your, what they call peak fertile years. Okay, this is about just your ovaries are, generating hopefully balanced amounts of hormones, and they stay in a pretty defined range. They don't really go out of that range. And that's because that's the range that's necessary for reproduction. And, generally speaking, unless you're taking birth control pills or other hormone blockers, your hormones will be in a pretty predictable range. Then you get to your late fertile years, which typically starts around 35. And if you've ever struggled with infertility and you were at that age, you might notice that that's some of the first signs that your hormones are changing, is that it's a little harder to get pregnant. Sometimes usually periods are still regular at this time. This is kind of the very beginning of perimenopause. Then we get into when perimenopause starts, and that's when our hormones really start changing and becoming noticeable. Again, this can be a 5-year period, it could be a 7-year period, it could be a 10-year period. Then you reach menopause. Now, I think it bears saying, if you have your ovaries removed for any reason, you will immediately go into menopause. So you skip all of this and you go straight to menopause. And then you have your post-reproductive years, where you're not in what we could call post-menopausal, but I think that term is confusing because it implies that menopause is something that you'll be done, like one and done, and that's not really how it works. So yeah. Okay, so again, this is the most sciencey part, I promise. So this is a graph that shows what's happening really with estrogen. Let's just look at the estrogen, which is the blue zigzagging lines. So in childhood, estrogen levels are really low. Now in your teens, they start kind of cycling. So they're up and down, up and down, up and down. And then they're up and down in this, where it says reproductive years, they're in this predictable pattern here. So the highs are like typical highs and the lows are typical lows. So everything is okay. Well, until it isn't, but it's not producing the full-on symptoms that we're going to see from perimenopause. Your body is growing in this range and the estrogen is helping you stay stable. When you get here to perimenopause, you can see that it's kind of like, it's very irregular and it's very erratic, and that throws off a lot of body functions. There's no predictability, which is probably one of the most frustrating aspects of perimenopause, is that, and why a lot of people feel like I'm going crazy, because you're not in a normal rhythm anymore. And then menopause is predictably low estrogen levels for the rest of your life if you're not on hormones. So it's basically like puberty again. It's reverse puberty. Okay, so what happens to your hormones in perimenopause? This is the key. Estrogen and progesterone levels were previously, they used to stay in a narrowly defined range. Now the problem is, when you get into the first stage of perimenopause, that sometimes your estrogen and progesterone are too high and sometimes they're too low. So it can be challenging to try to figure out exactly what's going to help you at what times and with what symptoms, because sometimes the symptoms are happening because the hormones are high and sometimes they're low. And that's one reason why a lot of doctors will say, oh, I'm not going to check your hormones, because it's too confusing. And there's some truth to that. Sometimes we do have to do some detective work and figure out what's going on with hormones, but a lot of times we can just help you feel better by looking at the symptoms. And looking, and of course there's other things that we can look at to make sure that it's not your thyroid, that it's not insulin resistance or diabetes or other problems that you can have. And that's sort of just like basic health screening. But if you're being told that all of that is normal, well, good, that's great. I'm so glad that's normal. And then there's this whole thing going on. And so that's what we had to kind of wrap our brains around. So the most common signs that perimenopause is starting are changes to your periods. And we're going to get more into that in the next slides. Something called vasomotor symptoms, which are typically is the technical term for hot flashes, but we're going to get way more into that. And then mood symptoms like depression, anxiety, and irritability. Those are the most common signs that it's starting. So what happens to your periods? You'll have regular cycles. Let's say averages 20s and early 30s. Again, these are averages. Some women go through early menopause before age 40. So these numbers will not apply to that person. Some women don't go through menopause till 55. So they may have regular cycles at 40. So it's not important, the number, but it's just to give you a general idea. Then when perimenopause starts, one of the first changes, everybody thinks that what's going to happen is their periods are just going to stop. And so that's like the last thing that happens. So the first thing that happens is that your periods don't get further apart. They actually get closer together. And so that can sometimes women don't even notice that. Some women a lot of women I talk to don't even track their periods at all. So, or they may just track the first day of bleeding or keep a general sense of it, but they may not be counting the days from, this first day of bleeding is considered day 1 of your cycle. And then, you count all the way up till the next day of bleeding. And then your cycle length would be how many days it was, did you get up to day 27? And then did you have bleeding the next day? That would be a 27-day cycle. So some women don't notice these subtle changes, but usually around late 30s, definitely early 40s. A typical sign of perimenopause beginning is that your cycle, where maybe your cycle was on average every 28 days, now it's every 26 days. And if you are tracking your cycle, you would notice that, because it means that your periods are coming more frequently, which is honestly kind of annoying. If your periods were every 26 days, in your peak fertile years, now there may be every 24 days, and that starts to feel like it's all the time. The other thing is that you can have subtle changes in your flow. So your flow can start to get a little bit heavier than it was, or it can be a little bit lighter than it was. And that could be a sign that your hormones are changing too. That is, if you go to your OBGYN and you say, well, I think I'm in perimenopause, but my periods are still regular, they're going to be like, that's not perimenopause. Now, first thing is, menopause is not required teaching in medical schools or nursing schools. There are about 80% of OBGYNs surveyed in a recent study by the Mayo Clinic. They looked at OBGYN residents in the US. 80% of them had not received more than 1 lecture about menopause. To be able to understand menopause, it takes a lot more than 1 lecture. It's hours and hours, because it's very, very complex from this side of the chair, right? And so they are not up to date, is what I'm saying. So early perimenopause, you'll have these subtle changes where your period's still in the normal range, but it's changed a little bit. Then there's a shift as you get towards the menopause transition. As you get to late perimenopause, your periods, you start skipping periods. So you might have, commonly, women will go like 60 days with no period, and then they'll have a period. So there you go, they skipped a period. And then a lot of times they'll be doing that for a year or two, like skipping periods. Maybe it's every 3 months, maybe it's every 4 months. Then after no period for 4 months, then they go, bam, they have a summer of periods every month. And they're like, you know, and then it goes back to every 6 months, and it can be very erratic. And then you'll know you've had your final period when it's finally been a full 12 months with no period. But that can take a while for it to kind of happen like that. Now, everybody's different. Some people don't go through every single stage, but I do break it into stages so that you can try to identify yourself where you are. Does that make sense? Okay, seeing some nods, seeing some nodding. Okay. Okay, so that's what happens with your periods. Obviously, if you don't have bleeding, you will not know what's going on with your periods unless you are super, super in tune with when you're ovulating and when you would be bleeding. And some women are in tune with that, even if they've had a hysterectomy and don't have periods. Okay, so hot flashes, right? Everybody's heard of hot flashes. Anybody out there having hot flashes? Anyone? Yay, some hands are being raised. So, I mean, you know, if anybody does anybody want to like chime in and say what a hot flash feels like for the people that out there that maybe don't know, maybe have never had one? And if you don't want to chime in, it's okay. I can do it.
I generally, excuse me, I generally feel like I'm kind of on fire, and my neck and face get all red. And a lot of the time mine come in the middle of the night and it wakes me up, and then I can't go back to sleep very well. But I'm on progesterone topical cream, and that seems to really help. Has really helped kind of put a stop to it. And usually I only have a problem if I have memory lapses and don't use it for a day or two. And then it comes back. But I can tell that it helps because when I'm diligent, I don't have a problem.
Awesome. Okay. Anyone else? I love that. So I think a lot of people will notice with hot flashes that they can be mild or they can be super severe. So a mild hot flash would be like, you just feel hot for a second. You're like, is it hot in here? And then it goes away. You know, sometimes it can feel like you're literally on fire. Sometimes women, it interrupts your activity. You need to strip off all your clothing. There can be like profuse sweating. Sometimes there can just be mild sweating. So there's a range of hot flashes. Some people can have hot flashes. I've had patients who have like 20 hot flashes a day. I mean, that's really problematic. You could see that is not doable, right? If you are working, trying to do anything, trying to wear clothing, women often report that it's very uncomfortable to wear a scarf or anything around their neck because this area gets really sensitive. Some women just have, hot flashes a few times a week, and then they tend to be worse at night, like Lori was saying. So, hot flash at night, you won't necessarily know you're having a hot flash until you wake up. And a lot of times they will wake you up. Sometimes women will not even, I'll have to ask, like, is anybody not sure if they're having hot flashes? Sometimes there can be like confusion about that. I think if you're waking up if you're getting woken up a lot at night, anytime anybody ever in the history of the world gets woken up, they think you feel like you have to pee and you go pee, right? So we all think that when we get woken up, it's because we had to pee. But what about all the nights when you didn't get woken up and you didn't pee and you were fine? So I think what we know about hot flashes at night is that they will wake you up. And so I always ask people, are you waking up to pee and are you hot and sweaty when you wake up? And if you are, then that's a night sweat. And that's something that has to do with your estrogen levels that are waking you up. So another thing is chilliness. So, a lot of women I know in Japan, for example, they don't even have a word for hot flash. The word for hot flash is cold chills. So women will complain more about the feeling of chilliness and the susceptibility to deep cold. And a lot of women will talk about, I used to go, camping in the snow, and I just can't get cold like that. I just can't get cold like that. Because they have a hard time recovering. And so that can be another aspect of this. Another thing that goes along with hot flashes is anxiety and heart palpitations. So sometimes anxiety, sometimes hot flashes can be triggered by something like spicy food or alcohol is a big trigger is alcohol or sugar. But anxiety, like an anxious thought or an anxious situation, can sometimes trigger a hot flash, or the hot flash can make you very anxious. Heart palpitations as well. So has anybody in here had heart palpitations? Had to go to the cardiologist? Say, I'm something wrong with my heart? This happens a lot. I wish I could go speak to the cardiologist and be like, can I just remind you all that this is, someone is between the ages of 40 and 57 and they come in and they're having heart palpitations, let's talk about estrogen. So it doesn't necessarily mean there's anything wrong with your heart. But it is, if they're happening a lot, it can be very reassuring to go get an EKG and go talk to a cardiologist. But 99% of the time that comes back normal and they say there's nothing wrong with you. And that doesn't feel good. Because you're like, well, why am I having these heart palpitations? Feeling like my heart's racing, like it's jumping out of your chest. And so these are all part of this syndrome of menopause, which is called vasomotor symptoms. VSM, vasomotor symptoms of menopause. And I like this term vasomotor symptoms because it's so much more than hot flashes, so much more than power surges even, which I think is actually power surges, I think gets to the point more, is that there's something that happens in our brain when estrogen goes out of range, either too high or too low, and it triggers these vasomotor symptoms, and it triggers this temperature control issue. And so sometimes it can have profound anxiety, heart palpitations. With anxiety, some women get heartburn. Some women will, lots of things can kind of be roped in to a hot flash. Some people just have hot flashes and they're like, Jill, it's not that complicated. But some people have more tricky symptoms. So this can be all of it. And estrogen replacement really is very effective for vasomotor symptoms. When we look at all the treatments in the next section, certain things are better for for other things, but estrogen, because we tend to have vasomotor symptoms when our estrogen is very low. And so if you think back to that diagram that we looked at earlier, that was the hormone cycle, right before you would have a period is when your estrogen is super low. So if you're still having periods, you'll notice the closer the further along you get into perimenopause, you'll notice that the week before your period or the 3 days before your period, you don't sleep well, you're hot, maybe you have worse anxiety, all of those things. And then it gets better. And it's not because you're crazy, it's because your estrogen picks up again and starts a new cycle. But it does get very low right before you're bleeding. And then when you're in, late perimenopause, your estrogen is pretty much always low. And so you can have these hot flashes like 20 times a day. That's an extreme case, but hopefully no one here is having that. If you are, please call me. Okay. So we talked about period changes. We talked about vasomotor symptoms. Now we get to talk about mood. Mood is finally being recognized as a huge vulnerability in menopause and perimenopause and menopause. But this is, now that more women are in science and more women are in gynecology, this is actually getting some attention. And I love men, but they don't know what we're going through. So we have to just take that into consideration. I highlighted this study because this was in 2021 and it was in Psychiatry Today or whatever journal that is, a psychiatric journal. So it's a window of vulnerability where hormone fluctuations or hormone changes can cause physical symptoms and psychiatric symptoms. It's a huge issue. And if you look up here where you have this sort of grinders here, so sleep problems, like we just talked about like a fundamental flaw in a design flaw here is that when estrogen gets low, our sleep gets disrupted with these vasomotor symptoms. If you're having mild vasomotor symptoms during the day, it's like, oh, I'm having a hot flash. Like, okay, like make space and like, slow down and get a fan and like you can deal with this. But when it's waking you up at night every single night, and now you have to like wake up and do your stuff, that's very difficult. And so then you get the brain fog and the lack of focus and the difficulty concentrating. And then you get the self-esteem issues and, beating yourself up and the stress. And then you have this, I didn't know what was wrong with me. I thought I was seriously going crazy. And so, when we look at it's like, is it the chicken or the egg? A lot of times fixing the sleep problems is like everything for women, because now you can sleep, now you can rest, and you can, you're resilient, and, you're an awesome person. And so, the stress, the anxiety, all of that goes down, your resilience goes up, and the brain fog decreases because you're not so tired. But I think a lot of us have gotten so used to powering through. So we think we should be able to power through when we get woken up like that. But a hot flash isn't just getting woken up by like a cricket on the wall. It's like, it's something very disturbing to your internal balance. And it has a greater effect than just like somebody being like, oh, whoops, sorry, I woke you up. I mean, it actually disturbs your homeostasis. And so we need a stronger cure sometimes than just, whatever you were doing before. Okay, any questions? I'm just going to take a pause for a second. Everybody good? Can anybody see the chat? Is there a question in the chat? I'm afraid to click out of my screen.
Hi, Jill. I have a question. This is
Okay.
Joyce.
Hi, Joyce.
Hi. If you're in perimenopause and you're on hormonal IUD,
Mhm.
your periods, how do you know if your estrogen is going up and down? And since you don't have periods, you don't know when it's happening because, they're ceased. So, yeah, that's my question.
Right. So yeah, so that's a great question. So like I said before, with you, when you have your periods have ceased, but it's like we've successfully taken away the bleeding, but nothing else is ceased with a hormonal IUD. So let me say this, more than 50% of the time, the hormonal IUD does not override your cycling. So to further confuse you, about 50% of the time, sometimes the hormonal IUD is enough hormone that it overrides your ovaries and you're actually not really cycling. That's one person. Most people, though, are still cycling. They're just not bleeding, or they have very little bleeding, or it's irregular. So it's actually very confusing. Yeah. So we're going to kind of get into the next slides. We're going to kind of get into what are some of the symptoms of perimenopause and how do they fluctuate? And you can it's something that you can't really know. I mean, I'll share myself. I'm having periods, and it's like, sometimes I wish I had just like they have like a continuous hormone monitor to tell me what my levels are. And, probably in 20 years that this generation is going to invent that. And that's going to be normal for us to be able to look on our apps and be like, oh yeah, today, this is what that is. And I actually think for perimenopause, it would be incredibly empowering information because it can just settle you to know that something is because of that. But it's really hard to know in perimenopause. If you came to my office and you're like, I want to know, am I in menopause or not? There's 2 labs I can run. One is called follicle stimulating hormone, or FSH, and the other is estrogen or estradiol. They basically mean the same thing. And those labs are really helpful for women to run those labs if you have a hormonal IUD or you've had a hysterectomy or an ablation. And you know, in midlife, I'd say it's helpful to run them annually, just because we can kind of check your progress. But it's only going to be useful when they show that you're postmenopausal, meaning that you've gone through the transition. When you're in perimenopause, it doesn't tell us anything. It's just a snapshot and it doesn't tell us anything. So I think, you know, scientists are working on a test for menopause, which I think is kind of what you're saying. But, you know, we're kind of going to get into a little bit of your question of how do I know when my levels are high and when are they low?
Okay, thank you.
Yeah. So, oh gosh. Okay. So estrogen in my body. Okay. So this can be a little overwhelming, but just know that our bodies are built to handle this, and not everybody experiences every symptom, right? But these are just, we're going to look at how big of an influence estrogen has on our body. Now, I'm not even going to talk about, in this regard, progesterone and estrogen. Those are also very important hormones, but it's too much to take in. And estrogen really is the main one that we need to focus on. So estrogen completely affects our brain. There's receptors all over our body, all over our brains. There's estrogen receptors that affect your temperature control, that affect your mood, and affect your concentration. So a lot of times what that looks like is when your estrogen is low, then your brain is activated. Sometimes low estrogen can create, like in terms of mood, sometimes low estrogen can be associated more with anxiety. And when it's too high, sometimes that's associated with irritability and sort of like high anger, like quick to anger. So that's just one example of that. It's also in our hair, skin, and bones. So obviously your skin does get thinner as we get older, and that's because of decreasing overall levels of estrogen, which decreases collagen in our skin, also can cause hair thinning. There's also estrogen receptors in your ears, in your taste buds, in your eyes. And so sometimes your eyesight can get poorer when you have estrogen loss. Sometimes you can experience vertigo or dizziness issues when you have low estrogen. And then bone. So bone and muscle loss is very common in old age, and a lot of it is related to estrogen loss over time. So sometimes the first sign of bone loss can be just achiness, bone aching, and sometimes that happens more when your estrogen is low. Times that your estrogen is low is going to be like if you're still having periods, the week before your period. If you are not having regular periods, then, you know, your estrogen can be low, you know, at least half of the time in perimenopause. There's also estrogen receptors in your GI tract. So in your throat, in your esophagus, in your stomach cells respond, the stomach cells that make stomach acid respond to estrogen. So when your estrogen is low, there's ongoing research on this. Is your stomach acid lower in estrogen? Do you have less stomach acid in menopause because of estrogen loss? And sometimes when we give estrogen back, women's GI symptoms decrease. Energy balance, how we break down our protein and our fat, all of that is so important. And we're going to talk more about that and how that you can really nourish yourself in menopause and why you really need to pay attention to this now. Your heart and your blood vessels have lots and lots of estrogen receptors, which is one reason why you can have more heart palpitations when your estrogen is low. And also, we're going to talk about this later, but giving estrogen replacement therapy, when you look at, when you compare users of hormone replacement therapy with non-users, like people who take it versus people who don't take it, they actually have fewer deaths from cardiovascular disease because estrogen is thought to be protective of the heart and the blood vessels. So that's an important thought too. Also, your ovaries, obviously very important for your reproductive tract, your uterus, but your vulva and your vagina. So there's lots of estrogen receptors in our vulva and our vagina. And as estrogen levels start to decrease, a lot of women will notice vaginal dryness, irritation, pain with intercourse where they did not have pain before, decreased orgasm where they previously did not have a problem, taking longer to come to orgasm, decreased sensation with the orgasm. And then also in the urethra and bladder, it's very common at, when women are postmenopausal to start having increased need to pee frequently, and just irritation of the urethra from low estrogen. So that's actually a very easy thing to fix by just doing topical estrogen. We're going to talk a little bit more about that in a bit. That's the easiest thing to fix of all of these things. Okay, so this is just a summary kind of everything we've been talking about. Vasomotor symptoms, that's from the brain. Insomnia, which has to do with vasomotor symptoms, that's from estrogen loss in the brain. Difficulty concentrating, to some extent that's related to estrogen. It's obviously related to, insomnia, and poor sleep quality. And it can also be related to low testosterone levels. So, is anybody here familiar with testosterone replacement, or has anyone tried testosterone? Just curious. Nobody. Okay. Sometimes we'll do testosterone replacement, especially if, low libido and difficulty concentrating are big problems and they're not being shifted by estrogen replacement. So that's another kind of like on the horizon things that people are doing, because testosterone is also really helpful for brain function, for muscle mass and libido. And that's exactly the same reasons that men use it. And so testosterone is not a male hormone, it's a human hormone, and we have a lot. And if it decreases a lot in menopause, then sometimes that can really help with the difficulty concentrating stuff. We talked about mood symptoms, muscle and joint aches, dislocating bones, thinning hair and skin, but the muscle and joint aches and the bones it's a pretty big deal, because, and we're going to kind of talk more about that as we go further into treatments. Vaginal dryness, vaginal itching, we kind of talked about that. Weight gain. Okay, so everybody that I see, a lot of people are like, what's up with this weight gain in menopause? And I think what we do see is an increase in body fat and a decrease in muscle mass. And that is no fun. And when you lose muscle, you lose function. Right. And so I think it's super important for us to focus on our muscles and our bones and not as much on the scale and the pounds, because actually gaining muscle, you could gain weight, which would be a good thing. If you gain muscle in menopause, I'd be psyched for you, because it means that you're going to stave off basically the problems of old age. You're going to be able to be independent longer. You're not going to be frail, and you're not going to have broken bones and you're not going to have that muscle wasting that happens as people get older. So I think we have to pay a lot more attention to that as we get into menopause, because menopause it forces us to look at aging, because with the hormone loss, we start experiencing all these symptoms that previously we were protected from because of our estrogen. And, for men, they don't have such an abrupt shift into aging. They actually start this process earlier than women, but it's very gradual. And so it may not be as noticeable for them until they're like, say, 60. But they've been on this train for a long time of decreased interest in sex, fatigue, gaining weight around the middle and losing muscle. But it's just much more of a gradual shift. And so for us, for menopause, it can feel like a really abrupt shift sometimes, like a real downshifting and very destabilizing. And so a lot of what I talk about with people is really like, how can we get you feeling better so that your priority can go towards, feeling better in your body and taking good care of your body, your muscles and your bones. just pausing here. Any questions about any of this? Oh, look, I can find the chat. There we go. And then I did put digestive issues on here. That's really common. Bloating especially is really, really common in perimenopause just because of the hormone shifts. And these are temporary things. Okay, so yes, this is where we have to dig really deep because this is a lot, you know, and I hope that I always hope that people have positive supports that they can turn to in this time, because this is not easy stuff to deal with. And I think sometimes people have no idea. Sorry, we just got a little chat there. Okay, I did put this slide in here. I wanted to make sure that we didn't not discuss this. Has anybody heard of genitourinary syndrome of menopause? Or vaginal dryness, vaginal atrophy? Is this like completely new information? Not new information. Sort of new information? Okay. Okay. So I'm just a little bit on a soapbox about this, and you know, fellow members of different medical associations that I'm involved in that do sexual medicine and menopause, like we're all on this soapbox because we feel like you should know this. Like if men had a condition where when they hit 45, their penis starts to shrivel up and becomes painful with sex, and now they can't have an orgasm, there would be a vaccine. You know, they would be talking about it all the time. It would be over the counter. The medication would be over the counter, you know. I mean, it's like, so we've been gatekeeping this information, and it's not helping women, because when you can literally, you know, you can literally die from this if you get, you know, women in their 90s who are in nursing homes, for example, with vaginal atrophy, have tremendous urinary incontinence because of the vaginal atrophy. And it's a simple solution to use vaginal estrogen to maintain the health of the vagina and the vulva and the urethra. And if you use that, you will have much, you know, less chance of getting urinary tract infections or vaginal infections. And women in their 80s and 90s can die of urinary tract infections. So this is really serious stuff. You know, it's not just vaginal atrophy or vaginal dryness. I think vaginal dryness is sort of a cutesy term. If you've, you know, if you've ever had severe dryness and pain with sex, it's not cute at all. So, you know, about 5 years post-menopause, what happens, we talked about that in the very beginning, I kind of alluded to that. Well, there's some permanent changes of menopause. You know, a lot of the stuff on the previous slide, a lot of that's temporary. You know, it may last a long time, and you definitely want to, you know, you want to figure out how to thrive, and you want to do that. But this is permanent. You know, there's thinning of the vaginal walls, thinning of the labia, there's decreased blood flow to the clitoris and the vagina. There's less collagen in the vagina. And so the collagen is what makes the lubrication. So there's less lubrication. So you can't get lubricated no matter how turned on you are. And so, you know, that can make sex incredibly painful. The opening to the vagina can actually narrow in menopause, and often does. So, you know, it's extremely common. The best treatment for this is vaginal estrogen. You know, vaginal estrogen should be over the counter, but it's not. It's topical. It's extremely low dose. It's like less potent than hydrocortisone cream. It doesn't do the same. It's like hyaluronic acid for your vagina. But it actually prevents these changes. It prevents thinning of the skin. It reinvigorates the vagina to be able to self-lubricate again. And it helps overactive bladder and, you know, frequent urinary tract infections. So that's actually good news. But I think when women talk about low libido a lot, the first thing I always do is, okay, are you using some form of vaginal estrogen on a regular basis? Because you're not going to, even if sex is just slightly painful, or if it's a little bit harder to get aroused, it sends a very not so subtle message to your brain to say, I don't want to prioritize this activity. And so libido is a very complex issue, and it can affect women throughout the lifespan, not just in menopause. But if you feel like you're having like burning or feeling of rawness or chafing, or just you think, I know what she means now, there's a lot of really easy solutions for this. And it's just a matter of getting in the habit of using it, like you brush your teeth or you use moisturizer on your face. It's basically like a high powerful moisturizer for your vagina. So never want to leave that out, because it's so important for our well-being and our health to be able to feel good about our intimate life. Yes. Cool. Okay. So these are we're going to get into like, what can you do about it? Right. So, first thing, these are just what I consider to be the goals. So actually sleep issues should be at the top. I don't know why I put it as number 4. Fix your sleep issues, and I say fix because it's like everybody is slightly different. So for some women, and we're going to talk about this in a little bit, but for some women, you may be ready for estrogen replacement. You're like, okay, and that will literally fix your sleep issues. For some women, a little bit of progesterone is all they need right now. That may change. You may need more later. You may not. If that fixes your sleep problem, great. If those things don't fix your sleep problem, is it a trouble falling asleep? Is it anxiety? Is it, are your adrenal glands really stressed out? Sometimes, we have to look more holistically. Sometimes people have something called sleep apnea, where they're not getting enough oxygen at night. That can affect your sleep. If you're not getting quality sleep, if you're not waking up refreshed, then we are not going to be able to handle the hormonal changes as well. So sleep is a huge priority, and I work with everybody on sleep, especially for reducing weight gain and improving mood and improving just your overall ability to take care of yourself with a healthy diet and exercise and all of those things. So when you don't sleep, you're just like, don't care, right? You're just like, I can't do it. So that should be number 1. Number 2 is avoid liver congestion. So, we talked about in the beginning, we talked about how sometimes your hormones are too high. So about half the problem is that sometimes they're too high. Sometimes they're too low. But when they're too high, it's like your liver is just trying to process all these extra hormones. And then if you just dump a bunch of stuff on top of it, it's like, yeah, I'm not going to deal with these hormones. And so the hormones just build up in your system and they don't get eliminated. And so that's a big problem when you're over 40, is that now previously your body could handle all these toxins on no sleep and a buttload of hormones. And it was like, yeah, it was okay. We're still filtering, but your filter slows down as you get older and our livers get congested. And so you really need to avoid liver congestion. So obviously stress is a huge factor, but you can't always control stress. Lack of sleep, I think if there's one thing you can do is to try to prioritize sleep. I have patients who literally be like, okay, I think I need to find another job because of this. It's like, this is really bad. When time comes for you to prioritize your sleep. Sometimes it's like, you got to get the cat out of the bedroom. I don't know. We tell ourselves all these things and we let these things go for so long. And sometimes people are like, it's because my cat keeps waking me up. And I'm like, we can't do this anymore. You got to fix your cat. Alcohol is a huge thing that you can't process as well in midlife. So that's something to pay attention to. If you enjoy drinking, if you're a big drinker, you may benefit from cutting back. If you don't only drink occasionally, you may have already noticed that on days when you drink that you really don't wake up very well and you don't sleep well. That's because your liver cannot process it as well, especially when you're in a high hormone state. Big doses of sugar kind of act the same way. It's like your body just takes a long time to process this, and it slows down the processing of hormones. And so remember, we want to improve our hormone processor because we're making more hormone than we did before. And that's a problem for your mental health and your physical health. So if you have symptoms, and if you're, then you really need to pay attention to that. There's also tons of chemicals in our food and our home, beauty products that act like estrogens. Never heat your food in plastic is one example. That is just putting more estrogens into your food, and then you're eating that and it's clogging up your liver. And then you're just kind of going on this cycle again. Nicotine, medications, all of that. Some of it you can't avoid. So paying attention to your liver is really helpful. And you're going to get some better tips in the next slides. The other thing is we eliminate hormones through our liver. We also eliminate them through our GI tract, through our bowels. And so if you're chronically constipated or chronically have diarrhea, you may not be eliminating your hormones effectively. And so you might have more hormones on top of all the other stuff, or more hormones than somebody else. So constipation, sometimes we're like, oh, constipation, I don't have nobody wants to talk about constipation. That can actually be a really big issue. The more constipated you get, the more that you're holding onto your hormones, and then the more constipated you get. So making sure that you're eating enough fiber is huge in midlife. People that eat more fiber, are healthier pound for pound in all corners of the world. Drinking more water, moving more, using castor oil. I love castor oil because you can put that right on your abdomen, and it helps a lot with just getting things moving. Getting physical therapy. If you have constipation or diarrhea, I always send patients to pelvic physical therapy because sometimes that has to do with how your pelvic floor and your hips and your spine is interacting, and not just the inside of your gut lining. Sometimes it has to do with the muscles surrounding your gut. All of those things, massaging scar tissue, deep breath work, all of those things is really good to pay attention to in midlife, because that's where we tend to get clogged. And then I always tell patients, fat is not the enemy. It's not about losing. I get that we all want to look the way that we did when we're 25, but that fat is not the problem. It's muscle loss. Muscle loss is what is muscles turning into fat is what's the problem. So you really want to focus on getting strong in your body. When you have more muscle, you're just healthier. Your body pulls sugar out of the bloodstream better when you have muscle, because the muscle uses more glucose. Fat makes more estrogen. And so we don't need more estrogen. I know everybody thinks they need more estrogen, but that's not the answer. It's more complex than that. And so we don't want to make more estrogen from our fat. We want to build muscle. Focusing on things that make you feel strong, that make your muscles have to work. That's the kind of exercise that I want people to focus on. And then, of course, fixing sleep issues. Okay. Do we need to take a little break? It's been an hour. You guys good? Anybody need a little break? Yes. Okay, let's take a 5-minute break and we'll come back, just a bio break. I'm gonna go get some water. I'll be back. Hey, anybody have any questions in the past few things? Any thoughts?
I have a question actually, and it's about the large amounts of sugar. What are large amounts of sugar or bunches of sugar? Like,
Yeah.
is that like an ice cream or a bag of M&Ms or, you know,
Yeah.
10
I mean,
sodas?
no, that would be like when you're a kid. That, like I think when we get to midlife, this whole thing is about really, to me, it's about like we're relearning self-care. Like, what does it look like to care for a midlife body? And everybody's sugar tolerance is really going to vary. If you have pre-diabetes or insulin resistance, we work on that specifically. So for that person, 3 M&Ms could be too much sugar.
Gotcha.
If so, and generally speaking, like if you, and oh good, Joyce, you're back, because I feel like I want to use your question, because I kind of debated your question about how do I know if my estrogen levels are too high. That's a really sort of sophisticated question, and I feel like it's like this question too, it's like these are where we get into, well, what's my unique situation, you know with sugar levels, like if you have pre-diabetes, all of this could be way worse. And so if you have a thyroid problem, all of this could be way worse. If you have adrenal fatigue, all of this could be way worse. So, I think it's important for everybody to not just do what I'm saying, but like to test for themselves. That being said, where I find, like with alcohol, right? Like sometimes women are like, I have to have my, I socialize with alcohol. I socialize for work. It's part of networking. I don't know. So we work on uncoupling sugar from alcohol, right? So sugar plus alcohol is like a triple whammy for your liver. So, like I love old fashions, right? Like a bourbon, and then all that stuff that's sugary, and that's a lot on my liver, and it's really hard for me to recover the next day, versus if I have like a vodka soda which has almost no calories in it, it's like okay, I'm okay right now. I'm in a different stage. If you are dealing with brain fog on a daily basis, hot flashes on a daily basis, a vodka soda may provoke symptoms. So it's partially the glucose in the alcohol, and it's partially just the alcohol. With respect to glucose, like 10 M&Ms, a big sweet dessert. Sometimes, a lot of times women will be like, oh, I'm just going to have a little bit of ice cream. Or, another strategy is to have protein and fat with the sugar, so that it slows the digestion of the sugar down a little bit, gives you a base for your stomach. I definitely don't, I'm not saying you need to be low sugar, but at the same time, it depends how you want to approach your perimenopause solution. Some people wanted to do this as naturally as possible. And I think that for if you are able to have like a very conscious diet with really minimal processed foods, minimal sugar, and meditate every day and get a lot of sleep, then you're going to cope a lot better with these challenges. Some people have really high pressure lifestyles and they're not able to make any of those changes. So, we have lots of treatments for the different level of where you're at. So being mindful of sugar is definitely important.
Gotcha. Yeah, that's helpful. Thank you.
Okay. And then Joyce, I wanted to did I clarify your question at all? I mean, it's sometimes it can be a little bit maddening to try to figure out, is this because my estrogen is high or is this because it's low? Because a lot of times the treatment's going to be the same. The self-care piece is going to be the same.
Okay.
Does that make sense? It's like, I don't want people to get too flipped out about that. Although, if you came in for a visit and you're like, we're having an appointment and we're trying to figure out your specific situation, then it may be easier to answer. Like I know when estrogen is high, A lot of women will have more irritability, more pain, more headaches, and worse allergies, more inflammation. And when it's low, you have more of those vasomotor anxiety, sleeplessness. That's kind of a general.
Gotcha. Okay. Yeah, that makes sense.
Yeah. Are you able to like, do you think you're still having cycles? Are you not sure?
Like the symptoms that you mentioned, I do notice that sometimes I get a little bit more anxious. Sometimes I feel like I have heart palpitations. I've never been diagnosed. And then other times I feel irritable. So it's kind of like I do feel that I do get a little bit of this with my estrogen. I just don't know, because I don't cycle, I just don't know when it's happening. But I do like the fact that you're giving symptoms. So when I have symptoms, I might know that, okay, my estrogen might be high right now versus low. So that does, it really helps.
Yeah. Yeah. It can help to track those things. There's also something called the Dutch test. Has anybody heard of the Dutch testing? So Better Living Through Science, I definitely don't think you need to do this, but there is a test out there that you can buy and take it home, and it's urine hormone testing, and you pee on these like little strips every day for a month every morning. And then you send them all back, and then 3 weeks later they send you a report of your hormones. And so if you want to know what your hormones are doing and then get on cycle with yourself, you can get like a cycle picture. There's also something called the Inito, which is like a hormone monitor that just came out. That's, I haven't used it myself, but it looks really cool. And because I talk about this all the time, Instagram will shows me all this stuff. Like, okay. And it's the same idea. Like you plug it into your phone, you pee on this little strip, and then you plug this thing into your phone, and then you put the strip in there, and then it tells you what your levels are. So you can kind of piece that together. So sometimes I'll do that with people if they, like if they're trying to get pregnant, or they want to really troubleshoot and dive in and really want the information. So there's ways to get it. But it's not always practical, and it's not necessary.
Got it.
Not required. Let me say that. A lot of times what we do is just like, okay, let's try this treatment. Did this work? Yes, no. And that gives information. So it's like, that's called like diagnostics. Like we're like, here, try this. If it works, we'll know that, it was related to that.
Right. Okay.
So this is sort of, before we get into the hormone therapy piece, which is very individualized, this is like for everybody. So these are the things that are proven treatments. So they have some evidence or clinical basis behind these are useful. So fish oils are so helpful for mood and cardiovascular health. I know we talk about it all the time. A lot of people are like, I'm not taking fish oils. Fish oils and a high quality multivitamin taken most day, everything on here is try to do it 75 to 90% of the time. That can really help, especially in early perimenopause, especially. Magnesium at bedtime, super helpful. I really like this reacted magnesium powder over here on the right. Any type of magnesium glycinate, because it doesn't spike your blood sugar, and it also doesn't cause diarrhea. So there's different types of magnesium. There's magnesium that's great for constipation. If you have constipation, you can take magnesium citrate. It's awesome. But you cannot take magnesium citrate in a high enough dose every single night and not have diarrhea. So don't do that. Magnesium glycinate at night, it really helps. It soothes the GABA receptors in our brain. It helps with anxiety, with migraines. It helps with headaches, irritability, and of course, insomnia and hot flashes. So that's a really easy thing to do. Always take magnesium, not with other supplements, because it will block the absorption of other supplements. So you're just throwing that money away. So always take magnesium by itself. Okay, reducing caffeine. So, if you have a lot of anxiety, and you drink coffee, you might want to try going off of coffee, switching to green tea or even black tea, something with less caffeine. If anxiety is a big issue, I think that's a good place to start. If you're just having, sometimes you're like, yeah, a lot of times we'll talk about this stuff and people are like, yeah, I am having that second cup of caffeine sometimes. It's really hard to do that in midlife, especially if you're having menopause symptoms. The caffeine, almost immediately women will get hot flashes. It just really taxes your adrenal glands, which is the structures in our body that make cortisol. It's like we make too much cortisol or adrenaline, and they get really tired. And if you kind of tax your adrenals, you will not have healthy hormones. Adrenal fatigue is something that some people have. Not everybody has adrenal fatigue. So this isn't like a presentation about adrenal fatigue. But if you go into menopause and you're already very burnt out, you've just been really stressed, you've been burning the candle at both ends, like you've had a very stressful 5 or 10 years before that, and you haven't been able to take care of yourself, and you've not been sleeping, etc., then your adrenal glands are just like barely functioning. And so the whole purpose of menopause is for your ovaries to like hand the baton to your adrenal glands. Like your ovaries are like, I'm not going to make hormones anymore. And the adrenals are like, I'm going to pick up the slack. But if you're like exhausted, your adrenal glands can't pick up the slack. So you have like no testosterone and you're just like crying every day and you're just like hurting. So, if that sounds like you may need to look at your caffeine intake, and all of these things really take it in. The other thing is eating 60 to 80 grams of protein a day. So everybody's always like, how much protein should I eat? Okay, go for 60 grams. The larger your body size, sometimes the more protein you need to eat. If you're very, very petite, you probably don't need, maybe you need 55 grams. But most women are not eating enough protein, and that is a huge impact on your energy levels. If you're not eating protein in the morning and you're tired in the afternoon, I'm like, okay, you have to eat protein to function. And somehow we got into this idea about just go, and not having full meals. And so there's something about eating a high protein breakfast every day as well that helps promote weight loss. It helps have healthy hormones, and it super helps with brain health. So definitely prioritizing breakfast. I know a lot of people are just waking up and they're kind of just having coffee and they're waiting until noon to eat. And that sets up a bad pattern with your metabolism where you're hungrier later in the day and your body like gets back to your liver, can't handle all that glucose and 8 p.m. And so you kind of like your circadian rhythms are off. So a lot of what I do with women with hormone repair is just like resetting your circadian rhythm. So eating 3 meals a day, getting enough protein with every meal, eating around the same time every day, going to bed at the same time, 75 to 90% of the time, waking up around the same time. These are the things that really help over time. Getting enough fiber is so important. Fresh fruits and vegetables are really the best way to get fiber. If you're not getting enough fiber, then sometimes adding a fiber supplement is really helpful. For most people, obviously, if you have, specific GI issues where you need to eat a low fiber diet, then just, disregard that. And then I always do look at, if somebody comes in with really severe menopause symptoms, I think it's really helpful to check for lost nutrients. Some people are very deficient in iron, vitamin D, vitamin B12 are the most common ones I see. If you're very deficient in any of those, it will feel like a hormone imbalance because it essentially is. These are fat soluble, important nutrients that your body needs to survive. And if you're low in them, you're going to feel terrible on top of all this stuff. So this is just like trying to lift the tide to get you to feel better. Especially if you're having heavy bleeding. I will say if heavy menstrual bleeding is an issue, then we definitely need to check your iron. Ooh. How do I get there? Okay. So I think we talked a lot about sleep. That's totally part of this too. I had to do a second slide because there were so many things. So regularly getting enough sleep, regular exercise is so important. It's so important. you know, really you want to get sweaty. You want to exercise so that you get sweaty. Cardio is important, but resistance training, strength training, it doesn't have to be in a gym. It could just be like moving things that are heavy. You know, gardening is really good exercise. Anything that gets your heart rate up, gets you a little sweaty, and makes you feel like your muscles are working, that's what I want you to do. That's a really, really important thing. And I think if sometimes women need hormone therapy to be able to do that, because they're so far behind in terms of their self-care. Because when we feel like terrible mood swings and not sleeping, it's like the last thing you want to do is exercise. And so if you have no energy and, you know, you're struggling in your relationships or your work because of that, you don't have the time, right? So really sometimes, you know, we do hormone therapy to get you to, as a bridge to be able to do these things. Cognitive behavioral therapy has amazing research behind its helpfulness with hot flashes specifically and sleep issues. That's a form of psychotherapy. If you found that to be helpful in the past, I would definitely go back to that. Mindfulness-based stress reduction is another strategy that has great evidence. So anything that helps you, you know, process your emotions and feel support in your body and, you know, love yourself more, super helpful. Vaginal moisturizers. There's one over here, Rosebud. I love this company. I put a bunch of these companies. They're also on my website. There's in the links page of my website, I have like vaginal products I recommend. I definitely get something that's formulated specifically for menopausal women, like menopausal intimate care. Your vaginal lips need balm sometimes when they get chapped. You don't want to put just any old cream on that, you know, because your vaginal pH is, you know, needs assistance. To, you know, you don't want to just put, like, you wouldn't just put soap on the inside of your cheek, right? Because that would burn. Same thing with vaginal tissues. So you want to be careful, but definitely all of those products are really great. I always think, you know, sometimes people will go like, you know, spend the weekend in a bathing suit and then they like had sex and then, you know, they're like, it's just a little uncomfortable. Vaginal moisturizers are great for that, just kind of like periodic irritation. You don't have to be afraid to use it. Silicone lubricants for sex. So using a lubricant, somebody told me that increases your chance of orgasm by 70%. I don't know where they got that information, but I think it's very true. And I promote lubricant with every single patient, regardless of age. I don't see why we wouldn't use it. I think that as women, we feel this pressure to be like so lubricated naturally, and then it's like very taboo to suggest lubricant. I hope you don't feel that way. I think lubricant for, you know, everybody having sex should use lubricant on all the parts. It just helps incredibly with comfort. And the silicone lubricants are what you want, not the water-based. Water-based lubricants are what's talked about in sex ed and for teens who are using condoms. If you're using condoms, then you cannot use a silicone lubricant because it might make tiny little holes in the condom. But so you would need a water-based lubricant. But you know, KY jelly and water-based lubricants are not sexy. You know, they don't last very long. They're squishy. They're not that nice. Silicone lubricants really glide and they are much sexier and better for postmenopausal tissues. Vibrators and toys. So we talked about, you know, how your vaginal tone can decrease, the blood flow can decrease to the clitoris, the opening can narrow, the tissues thin out. Well, if you maintain regular, you know, use of your vagina and your clitoris with a toy and a vibrator, you can, to some extent, offset that. And so I always recommend, you know, pleasure is a huge benefit for mental and physical health. I talk about this a lot with patients. So this picture here is the Lioness vibrator. And they actually they're like geniuses. Whoops. They made this vibrator that attaches to an app so it can tell you how strong your orgasm was. So it's just kind of a nerdy thing, but it's kind of fun. Okay, I don't know how to get back to this. Shoot. Oh, there we go. Okay. Okay, so now we're going to divide the group into early perimenopause and late perimenopause. So the early perimenopause people are the ones that are still having periods more than 6 times a year. Now, Joyce, I'm going to pick on you. If you have an IUD or you have a hysterectomy, you may not know if this is you, because you are having 0 periods, but that doesn't mean you're not having cycles. So I really should have wrote if you're still having more than 6 cycles per year. And, we can get more information. If you need that specific information, we can figure out if you're cycling or not. Does that make sense? So if you're still having more than 6 cycles a year, these things are helpful. So DIM supplement, calcium glucarate, Vitex, these are herbs that are specifically formulated to help you decrease your estrogen and improve your estrogen balance overall, because that's the problem in early perimenopause, is the estrogen balance is off. So these are really helpful. I sometimes will prescribe, if somebody's already taking like a multivitamin and just wants to add things, I might just say, well, why don't you get just a DIM supplement and a Vitex supplement? If they are like new to all of this and they're not taking a supplement, you can get supplements that have all of that in one. It's really just about consistency. Antioxidants are really important. There's antioxidants like, blueberries are an antioxidant, green tea is an antioxidant, NAC, quercetin, there's like a million antioxidants, but don't ignore antioxidants. Antioxidants can really help, especially with this question of how am I processing sugar weird? Like I still want to go out, but like, am I getting enough antioxidants? You might not be getting enough antioxidants. They're really anti-aging. And so looking at that, adding that into your diet. Ashwagandha, rhodiola, holy basil, these are herbs that are, they're adaptogens. These are really popular right now. There's lots of products that have like ways that you can take this. You don't have to just swallow a pill. There's teas that have this in there and you can add it to your coffee. And there's all this fun stuff out there. I try not to like do too much like specific product, like I want you to buy this one product. There's lots of ways that you can do that. But those can be really helpful. And then if you have really severe moods, anxiety, sleep issues, and hot flashes, and I think generally speaking, I'm always surprised when people don't get to that point. So it's completely fine to be like, check that box. Like, I don't mean just like, it has to be so terrible. Like just, it's really bothering you. Then bioidentical progesterone, I think someone said before, was on the topical progesterone cream. Yeah, Lori. So, there's topical progesterone. And then there's oral progesterone, which is a pill, like a capsule that you swallow. I find that the capsule is usually more, it's a little bit stronger. I think with the cream, sometimes it's a big molecule. Progesterone's a really big molecule and it doesn't always go through the skin as easily. And so, but if you find the cream is helpful, keep doing what you're doing. I usually will start people on the oral capsule just because I think it, just so that we just go straight for that. But the point is that it's usually prescription. There are some over-the-counter progesterone creams. Some of them work better than others, and sometimes it can be hard to figure out the dosing for that. So again, I usually will just use the oral progesterone. And that's something you can take, like, for example, if you're cycling and you know when your period's coming, then you can just take progesterone the last 2 weeks of your cycle, and that can really lift your mood and help you carry you through, and you can avoid the insomnia and avoid the mood swings, the premenstrual issues. If you don't know when your cycle is, or if you feel like your symptoms are all the time, then you can just take it every day. The only side effects that I see with progesterone is that sometimes it can cause some breast tenderness when you first start. It kind of feels like that kind of like premenstrual tenderness. Usually that goes away within about a week of starting it. And then sometimes it can cause some irregular bleeding when if you are taking progesterone, if you take progesterone every day and then you just like forget and go on vacation and stop taking it, you might have some spotting because it can kind of confuse your uterus a little bit, but it's not harmful. Progesterone does not appear to have the same risks as, say, the type of progesterone that is in the birth control pill. That's a synthetic progesterone. That's a man-made chemical that acts like progesterone and does have some negative health effects if used for a long period of time. Whereas the progesterone that I'm talking about in menopause care is bioidentical, which basically just means it's the exact same formulation that your body makes. So it's synthesized in a lab, but it is molecularly looks exactly like progesterone. And so it acts similar to progesterone. The other thing is birth control. And everyone always looks at me like, no, like I'm not doing that. But sometimes if you feel like you're just on a roller coaster of emotions and you are still having periods, we can't give you estrogen because that you're still having periods. So sometimes we need something stronger, and the birth control pill can be extremely helpful because it tells your body to stop cycling completely. And so you kind of just get a break from the symptoms. So sometimes that could be a good short-term solution, like in your 40s, but that's only appropriate if you don't have high blood pressure, if you don't have obesity, if you don't have liver problems. Otherwise, it's not really there are some risks associated with the birth control pill. And a lot of times women are like, I'm not doing that. So, I get it. But it can be helpful. Okay. Yes. Okay. Here we go. Okay. So when you finally get to late perimenopause, it's almost like, yay, because now I can use estrogen. That's how a lot of my patients feel. And I do think it is a little bit like that. It can be hard to troubleshoot when your hormones are all over the place. It's just like antioxidants and sleeping and, therapy and all of these things. And it can be a lot of work. Then when you start having fewer than 6 cycles per year, yes, you feel bad, but there's also there's more potent solutions available for you because you're not really having periods. Does that make sense? So that's when we start looking at hormone replacement therapy. I also want to say, if you have had a hysterectomy at any point, you may be able to use hormone replacement therapy earlier because you don't have a uterus, you're not having bleeding. So this isn't completely, it's a little difficult for me. Like, I always feel like I'm giving too much information. It's hard to kind of give a universal recommendation. Oh. Okay, there's somebody else in the waiting room. I don't know if anyone else is supposed to be here, so I'm not sure what to do about that. Okay, so any questions so far? Anybody? Does anybody know this person in the waiting room? Okay, I don't know what to do about that. It's weird. Okay, so first line treatments for hot flashes, sleep disruption, and mood in menopause. The first line treatment is estrogen replacement. When we talk about hormone therapy, when we talk about menopausal hormone therapy, we're generally talking about estrogen and progesterone because estrogen is kind of considered the most potent and has the most health benefits. You can't take estrogen without progesterone if you have a uterus, because the biggest risk associated with estrogen is that if you take a lot of estrogen, over 6 months, and you have no progesterone in your body, you will build up a thick uterine lining, and that can turn into uterine cancer if it goes unchecked. So you have to take progesterone. So when we talk about menopause hormone therapy, we talk about estrogen and progesterone together, but we're really talking about the estrogen. Now, progesterone also has a lot of health benefits, but the estrogen kind of gets more play because it's just more. And then we also have testosterone replacement. I'm not a fan of combining it all in one. I like to use, in my practice, I use pretty much FDA approved products that are available with insurance, with most insurance plans, to try to simplify this process for you. So it's not very expensive. You don't need a lot of lab monitoring. Some people I know will do compounded hormone therapies where the estrogen, progesterone, and testosterone is in one cream. I'm not a big fan of that. But regardless, so you can look at estrogen, progesterone, and or testosterone replacement. But I kind of want to focus more on estrogen for this class. This is kind of like a beginner's class. And I think testosterone is a little bit like, it's a little intermediate. So it's like adding another thing. So here I have, obviously, here's an example of some testosterone gel that I do use a lot and that works great. That being said, I'm happy to talk about it, but I just don't want to confuse you guys. This is the progesterone capsules. They're just like little egg-shaped capsules. You take them at night, 30 minutes before bed. You can take it with your magnesium. Progesterone at night helps you feel warm and fuzzy and sleepy. It decreases anxiety and helps you go to sleep. So it's best taken at night. These over here are the estrogen examples that I use the most frequently. So there's one called Divigel. And you can see on here, Divigel eliminated nearly 90% of hot flashes. So estrogen is so powerful in eliminating hot flashes. When you are not sleeping and you have brain fog and hot flashes at night, that's really what most women end up wanting to do. The Divigel is great. It's a gel that you apply on your skin, and it has to be applied daily. So sometimes people don't want to do a daily thing, and then we look at the patch. This is the Vivel Dot. I think it's got, you have to move this out. Yeah, you can see this patch is tiny. It's not like a big giant patch. It's this tiny little patch down here. So you put that patch on, that's the smallest patch that you have to change twice a week. And it works wonderfully. There's different doses. So sometimes we have to start at one dose and then we go up if it's not enough. Sometimes we come down if it's too much. But usually, we can get people feeling good within a couple of weeks. And then there's also larger patches that are weekly patches that you just remove and change out the patch weekly. I hardly ever use oral estrogen anymore. Oral estrogen was what was used in the past, and these are just so superior. Oral estrogen, when you take a pill of estrogen, it goes through your GI tract and it goes through your liver, and it elevates your clotting factors and it messes up your hormonal system. And so it can actually decrease libido. It can actually decrease your testosterone, and it increases the risk of strokes and heart attacks, which is what we had seen in the past with hormone replacement therapy in older formulations, especially when it was given to women who were in their 60s and 70s that maybe had underlying risks of heart attacks and strokes already. And then if you throw oral estrogen on top of that, it can be really harmful. So nowadays we just use the transdermal method. Transdermal meaning it's something you put on your skin. It just goes directly through the fat layer into your bloodstream, and it doesn't increase your risk for stroke or heart attack at all, significantly at all. So this is a really awesome product. And then this one here, this is what the vaginal estrogen suppositories look like. They're so small and cute. I use lots of different forms of vaginal estrogen. This needs to be used also. If you do nothing, you should still do estrogen suppositories, in my opinion. Estrogen suppositories do not get into your bloodstream. They're very low dose. They just dissolve in the vagina, and they just touch all the cells in your bladder and your vagina and your cervix and your clitoris, and that's it. They don't go into your bloodstream. So they're safe for literally anyone at any age. There's no limitations on that. Whereas, with estrogen systemic, for menopause, we do have some more considerations because that does get into your bloodstream. Okay. So, stepping back from hormone therapy, there's lots of other things that are effective for, that have a low to medium effect on hot flashes. So, and vasomotor symptoms and mood and all of it. Sometimes people's main complaint is like joint pain, anxiety, and bloating. And I'm like, okay, let's try hormone therapy. And then they're like, oh my God, I feel so much better. So, you know, we say it's for hot flashes, but it really can, like we saw that slide in the beginnings, you know, estrogen affects, we have so many estrogen receptors. A lot of times, a lot of our menopause symptoms resolve with estrogen. So all of these treatments here work on different levels. So the first row here, these are medication options that you can get. If you have active breast cancer, if you've had breast cancer in the past, we generally don't recommend hormone therapy. That's getting a little controversial now as women are kind of pushing back and wanting more research. And I hope we're going to do more research on that. But as of right now, if you've ever had a stroke or a heart attack or breast cancer, then you may not be able to use hormone therapy, systemic hormone therapy. You can still use the low dose vaginal hormone therapy because it doesn't get into your bloodstream. So these are antidepressants, Paxil, Zoloft, duloxetine. They have a very mild effect. If you're already taking one of these medications, they may be doing more, they may be helping you more than you realize. They may be they blunt hot flashes. They don't eliminate them. So I think that they can be very useful sometimes. Gabapentin is another one. This is a newer drug that's just been released, fezolinetant, and it's shown effectiveness in research. And then DHEA. So these are kind of low to medium effect. Acupuncture, I have a lot of patients who used acupuncture to treat their menopause symptoms for years, and then they're like, okay, this is not working now. I really want to do hormone therapy. I think it's a wonderful adjunct, and also I think it can be really effective for low to medium symptoms. Mindfulness and cognitive behavioral therapy, there's great research on that, specifically for hot flashes and insomnia. So don't underestimate, it's not to say that it's in your head, but don't underestimate the power of neuroplasticity, right? Like of your brain's ability to shift your physical experience. So that's a really interesting area. If you're into herbs, I really like herbs a lot. Motherwort tincture is a great tincture to just keep around and just drop in your water if you're having heart palpitations or anxiety. It's very heart protective. It really helps with just ease the sort of worries that can come along with menopause. This is a list of phytoestrogens. I'm sure everybody's heard of this. Phytoestrogens, you know, soy. Well, there's so many herbs and plants and foods that act like estrogen. So increasing your dose of those or increasing those in your diet can have a mild to moderate effect. There's some over-the-counter supplements, Estrovera, Estroven. Those are sold everywhere. Those can be really helpful for mild to moderate hot flashes, and they have phytoestrogens in them. And then drastically, I put drastically reducing sugar and alcohol here. Mandy's like, haha. Well, I put that there because it's like, if you want, like, eating low sugar is healthy for lots of reasons, but it's not the answer. I do see that if women are, you know, on a very, just a very natural diet, sometimes that does help, but it's actually, the research doesn't show that there's a good association between diet and or weight in terms of who's going to have, as predictors for who's going to have worse menopause symptoms. So I think a lot of the things that we kind of guilt ourselves about are not showing up in the research as like really good ways to reduce your symptoms. So this is kind of, I can show you guys, I have some, I can make this available to you if you want to see some of the supplements that I recommend. I use Full Script. This is what it looks like. You go on here and you can see that, this is my perimenopause essential self-care protocol. And I'm not saying you need to take every single one of these things. I'm hoping that, if you're going to be using this to treat yourself, you can kind of like read through and kind of decide what speaks to you and what in your stage of life. And they've got, I've got the vitamin D that I like. I've got the couple different magnesium options, the fish oils. This is the multivitamin that I really like. if you have low iron, this is the #1 supplement that I recommend. This is a really good early perimenopause supplement that has all of those, the DIM, the calcium glucarate, the Vitex, all rolled into one multivitamin. So it's just simpler. I really like that. Here's DIM if you're like, oh, I'm just need some DIM, or Vitex. Here's the Estrovera, which a lot of people really like. So you can kind of look on there and see if it's helpful. Okay, let's see if I can get back to, I'm getting so good at this. Okay. So, everybody's experience in menopause really is tremendously unique. There's a huge amount of variation cross-culturally. I definitely am speaking to like typical North American woman here, from North American culture, and every culture approaches menopause in a unique way, and different people experience it differently, even in families. Just your mother's experience may not be the same. It's not like destiny. So I think it's really important, just getting back to like having a lot of kindness for yourself, and really just being okay with just embracing what you need and being okay with that. And really, that is the task of menopause. And that is the journey, is like, how do I find out what it is that I need at this time? And that can be a huge revolutionary act for women to be given the space to do that. So I applaud all of you for coming to this and for learning about it. And yeah, I would love to take more questions. If anybody has specific questions, go ahead.
I have a question. On the supplements, I have been told, I've been in perimenopause now for 12 years, that I'm still having a period every month.
Okay. Oh, that's so
So
frustrating.
I know. So on the supplements and recommended things on your list, are they things that take time for you to start seeing a difference? You have to build up with it, or is it pretty instant once you start taking them that you feel better?
Good question. So I would say Vitex specifically.
Okay.
And Vitex takes 3 to 6 months to be effective, but it's an extremely profound herb. So it's really
Okay.
good to, it's not expensive at all. And you can take, it's very easy to take. It doesn't have any side effects. The DIM, I think, does work faster. Magnesium can work like the same day you use it. A lot of times people will just report, oh, I sleep so much better with that. And then if you have, I would say, maybe we need to check your iron, make sure that, do you have any nutrient deficiencies going on? And also just to kind of look at like, what is the big picture? Sometimes you need help getting off of that road of cycling. And, there's definitely options, that non-surgical options. Let's just say that there's definitely non-surgical options. Because that is a long time, and that can be a frustrating, but you may be closer than you think.
Okay. And one other question. My doctor recommended evening primrose oil. Is that something you've ever used or know anything about?
That's a pretty old school recommendation. I think that like people that may not have updated their menopause knowledge, I could see them like bringing that in. I think I used to say that before I, started really treating menopause patients. There's not really good evidence for evening primrose oil. But if and I think that there's a lot of marketing that's done to women, and sometimes it's placebo. So there isn't good research that I found on that.
Okay. Well, I started taking it and I don't feel anything. So
Yeah,
I was just curious. I definitely want to give some of these other things a try and go from there. So
yeah. I think it's all about, and this isn't often what we want to hear. I think it's all about, symptom relief so that you can live your best life, because it's temporary.
I have a question about I have always had super thick hair. Like I used to call my hair fat. I had fat hair. And in
Yeah.
the last couple of years, I've lost so much. And I still have a lot of hair, it seems like, but I just am wondering, are there any supplements or things that you recommend or things that you know have worked to help slow that down?
So yeah, so that's a really common question. And it's really common experience. So yes, I'll give you my like 2-second hair spiel. So like biotin, there's really no research behind the biotin supplements, and the hair, nails, and skin supplements all have high dose biotin in them. I don't recommend that you go out and spend a lot of money on biotin supplements. One thing is there's a natural hair loss that happens in menopause, and it's the same thing that happens postpartum as well. It's called telogen effluvium. It's like a thing that's going to happen, and it's like somebody's going to have an analogy. It's like, it's like thinning the herd. Okay, there's like a thinning of the herd that happens, and when that correct, and then it self corrects. So there's some thinning, and then it stops eventually, but it can be very alarming when it's happening. So that definitely happens as a response to hormones. The other thing is looking at other causes. So is your thyroid okay? How's your iron levels? Your thyroid's not okay. Okay. If your thyroid's not okay, then
I have hypothyroid and I do take medication, but
okay. So like kind of looking more into that, like, is your medication working? Do we need to do something different with your medication? How's your iron and your vitamin D levels? Because those are building blocks for hair. And then also, how's your testosterone? If your testosterone, I didn't really talk about testosterone very much because I didn't want to confuse everybody, but testosterone can go up or down in menopause. Sometimes it goes up. And if it goes up, that can contribute to hair loss. So sometimes it's like looking at the whole picture is like, are you having hair loss because your testosterone is high? And like, we don't necessarily want that to lower it, but we want to help you process it better so that the hair loss stops. Or is this just a normal thing that's happening because it's your time to have your hair loss and we're all going to get there and it's going to stop? Or is it your thyroid? Yeah, sorry. I did want to go, I have a couple of, these are just a couple of additional slides, and I don't want to just, I want to leave you with this. There's some pretty serious health benefits to hormone replacement therapy that a lot of people won't tell you because they just don't know. There's a lot of misinformation in the medical field, as I was saying before. Menopause has kind of been given the shaft in medical and nursing school for at least 20 years. So if you know anyone that's gone through early menopause, they really benefit significantly from hormone replacement therapy, and because they're at higher risk of early death because of estrogen loss. So, I don't think I want anybody here to be afraid of menopause, but if you do go through menopause earlier than 45, then you definitely should talk to someone about hormone replacement therapy, because it decreases the risk of type 2 diabetes, decreases the cardiovascular risk and stroke and all-cause mortality. This is also sort of in general for everyone else who goes through natural age of menopause. The average age of menopause, if you start estrogen replacement within 10 years of menopause, there are a lot of benefits. So obviously eliminating hot flashes is a huge benefit, improving mood, improving sleep, decreased pain from fibromyalgia and inflammatory arthritis, improves memory, and improves glucose levels. So in people that have a risk for type 2 diabetes, sometimes that's really significant. And then women who take hormone replacement actually die less often from heart disease. And it stops bone and muscle loss. So it's something that sometimes women will consider just on a preventative level. Unfortunately, where we are with the science is that they're not quite recommending estrogen yet for preventative benefits. But as a practitioner, I definitely contest that. And I think, in the future that may be coming down the pike. because of there's so many health benefits, it's almost like, well, okay, you know, like seatbelts. Now we recommend them to everybody, you know. And I think it's similar for testosterone replacement as well. With men, that's the main hormone that they have. And there's, you see a lot of this replicated in the science around testosterone for men. And then just a real quick, the risks of estrogen. Everyone's always like, what are the risks? The biggest risk when you take transdermal estrogen, which again is the gel or the patch that you put on your skin. So it's not a pill. If you take a pill, there are increased risks. But if you do it on your skin, the only risk is that if you don't take your progesterone, you can get endometrial cancer, because you're not, it's, you know, that's a serious risk of estrogen. So, you know, I always talk a lot about the role of progesterone, and do you have enough progesterone, and are you taking your progesterone? And if not, let's figure out, do you need an IUD? That's a valid form of progesterone that's protecting your uterus. Or do you need to have a combined patch, estrogen progesterone patch? You know, or are you happy taking the progesterone capsules? Most women are happy taking the capsules because they help them go to sleep. But that is the biggest risk of estrogen. So it's just about, are we correctly prescribing it, and are we correctly taking it? We're all adults here. I think everybody can, you know, absorb that. So I don't think it's a huge risk. I think for most women, the benefit outweighs the risks. And then again, vaginal estrogen does not even go into the bloodstream at all. So it's safe for literally your grandmother in a nursing home. And it would decrease nighttime urination and the risk of UTIs for her. So I do recommend it even for older women, especially. And actually, there's a lot of research coming out now that women who take estrogen have a decreased risk of breast cancer, strokes, and heart attacks when it's taken in this bioidentical form transdermally. So this is modern hormone replacement therapy. So it's definitely evolved a lot in the past 20 years, even, or 50 years. And actually, I think estrogen therapy has been around since 1940. So we're almost at 100 years. Pretty cool stuff. So I'm happy to send you guys these slides if it's helpful. Yeah, happy to answer some more questions. I have a couple more minutes. If anybody needs to go, definitely free to go.
I just had one question about if you do enter into the next phase and you take hormone replacement therapy, is it something you do for life, or is it just for that transition period?
Oh, that's a good question. So yeah, I mean, they used to say, you know, you needed to stop at a certain age. I find that it's really a practicality consideration. So you do need to come back. In my practice, the way I do it, and the way a lot of menopause specialists do it, you have to come back annually, because we have to kind of see, do you still want to do it? Like, have you had a stroke? Have you had a heart attack? Have you been diagnosed with breast cancer? You know, are you getting your mammograms? You're getting your colonoscopy? Because estrogen is the growing hormone. So estrogen makes things grow. So if you do have cancer in your body, it may grow faster, but then we can detect it earlier. So, you know, it's important to kind of stay on top of that. My oldest patient on HRT is 80. She just turned 80. She's super happy on her HRT. You know, the benefits outweigh the risks for her. You know, for some women, it's a cost consideration, or maybe it's a practicality consideration. I don't want to do this anymore. You know, if you go through menopause, and let's say you have your last cycle at 51, and then at 55, you're like, I want to see if I can go off of this. You have to wean off very slowly with estrogen, because estrogen is addictive in terms of, you have to wean slowly off of it. If you stop taking it, you're just going to go right back into menopause. It's like your body's like, right? So obviously you wean off slowly. I think sometimes 5 years is too soon. A lot of times women will just, the hot flush just come right back, and then they feel defeated. And it's like, well, okay, you can try that. It's fine. But a lot of times it needs to be for a longer period. Sometimes, you know, it's different for everybody. At 60, sometimes women are like, okay, I'm going to wean off of it, and they're fine, or they keep going. You know, they like the benefit of their skin and their hair, and they like how they feel, and they don't want to go back. So it's really individualized. There's no, like, you have to go off at this time. Yeah. So who knows? In the future, maybe they'll make, I know there's researchers working on like an artificial ovary that we could just implant into our bodies, and then it would like do all this work for us. We wouldn't have to apply anything. And I mean, it's crazy stuff, but when you start to think about it, it's like, oh, women in tech is really important. It's really good. It's a good one. So yeah, any other questions? Did I answer your questions?
I just wanted to say thanks. This was really, really worth every minute, and I learned a lot. Thank you.
Yeah, thanks for saying that. I'm glad. So glad. Yeah, if it helps you feel more empowered and helps you kind of tell a friend, that's really what I hope. So go out and share this message. There's really good books about menopause too. There's great podcasts. There's a lot out there. There's a lot of people talking about these. Okay.
Thank you.
Yeah, you're welcome. Well, I'll just hang out
so
for
much.
you if anybody has any questions.
Thank you.
Yeah. Nice to meet you all.
Thank you.
Thank
Mhm.
you.
You're welcome.
Thank you.
You're welcome. Hi.
I'm trying to leave. I just don't know.
So you're in the wrong window. So hover over the Zoom icon on the bottom, and then go to
Bye,
Zoom
thank
meeting
you.
on the right.
Yes, bye-bye.
Oh, there we go.
There you go.
Bye.
Bye.